Today we got just an amazing topic for everybody, something that's very important, especially in light of the oversight we get with regard to medication management and the need to ensure the safety of those that we serve. It's one of the most important topics we have. And it's critical to the maintenance of health for those with intellectual and developmental disabilities. It can reduce adverse reactions and the risk of hospitalization, and it can place the patient as the primary focus, delivering better targeted care and better informed individuals. Today we have Lisa Parrino. And first of all, Lisa, thank you for doing this. Your reputation is amazing. I've heard from a number of people. Lisa is currently the nursing coordinator for the Arc of Alachua County. And from those that have been on these calls before, the Arc of Alachua County, they serve a lot of clients with serious medical conditions, including PWS and other disabilities. But she's been there for 13 years, and she's experienced in working with intellectual developmental disability population, teaching basic medication administration and doing medication validation. As the call goes on, if you have a question, you can raise your hand or you can put it in the chat box if you don't want to talk. And at this time, Lisa, we're all eager to hear so we can be better, help take better care of the people we serve.
Well, thank you for this opportunity. I would like to just give a quick little background to my situation. I have been a nurse for numerous years. I graduated from the University of South Florida with a Bachelor of Science in Nursing, worked for a few years, took time off to raise my children. And when I got back into the workforce, I actually started as a DSP at a facility in Massachusetts. When I moved back to Florida, I had the opportunity to use my license as well as the experience I gained from working with the IDD population in Massachusetts. So it was the perfect fit for me when I came back to Florida. I started here at the Arc of Alachua County as a nursing educator, which was doing the medication class, and have gradually worked my way into the nursing coordinator position. Now, I know a lot of ARCs around the state do not actually have nurses on staff. So I imagine there's a lot of information that you have to gather from the nurses that you hire to come and do your validations or your trainings. But when I was asked to do this little presentation, I tried to put together a synopsis or a table of contents, as you will, for what I would view as the components that go into safe medication management in providing care for our individuals so that we maintain their health. My three components that I came up with was good healthcare providers, a pharmacy connection that is beneficial, and the direct support staff. So I'd like to talk on those three particular components, and I'd like to start with the healthcare providers. Right now, healthcare in general, as I'm sure all of you have found out in your own private lives, has been a bit challenging. It's hard to find a primary care physician. It's hard to find specialists that can see you in a timely manner. And I think that that gets even more complicated when we talk about our population. It's hard to find healthcare providers that understand the nuances of the IDD population. There are different things that you have to factor in, behaviors that keep people from attending appointments as scheduled, and then you've got to reschedule them and you end up being delayed in getting the health care. These providers also have to meet our APD standards. So there are different things that we ask of providers because they are serving our individuals than we ask for ourselves. And I think that that is a bit challenging for everybody. For example, when you go to the ER with your clients and the discharge paperwork says call your doctor within 3 days or get an appointment with your primary within 2 to 3 days, I have found, and most of the managers that work in our group homes have found that that doesn't happen. It happens maybe 2 weeks out, and in some cases even further out. So I think that that's one of our primary problems right now, is just finding a doctor or a set of doctors who are willing to take on our population. Just because there are a different set of abilities. The clients don't necessarily understand the importance of attending these appointments, or of taking the medications or doing the procedures or treatments as ordered. So I think that that is one of our dilemmas right now. I don't know if everybody else is finding that to be the case, but it certainly is the case in Alachua County. Even with UF and all the doctors here and all the doctors that are training, it still is very interesting trying to get an appointment. The other component that I like to talk about is the pharmacy. We have a commitment from a pharmacy. Now, our organization made a commitment to going to electronic MARS. That has been a lifesaver for the number of people that we serve. It was very challenging to go through each one every month and make sure that everything was up to speed. We still do that, but with the assistance of our pharmacy, it is immensely easier. It is a commitment, and it's a cost that I'm sure not everybody can afford, because the cost cannot be passed on to the client. It has to be absorbed by the organization. So, but it also has led to a reduction in medication errors for us. The pharmacy will also reach out when a prescription is not written to 65G standards. For example, the parameters not being added to a PRN medication. So with that, it's just very helpful, because it's not just our staff calling the doctor for those. The pharmacy is trying to procure that kind of documentation, so that when our monitors come in and look at our prescriptions on our PRNs, everything meets standards. I think that having a dedicated pharmacist has helped us as well, just because we have one pharmacist that pretty much handles all of our medications. They have a staff, and that has been very beneficial. There's one person I can call when I'm running into problems. I think that if I had to call 5 different CVS's around town, or Walgreens, it sure would limit the continuity. I'd spend every day on the phone. So it really does help having a pharmacy that's committed to our population. But I think that the key component to everything here is our direct support staff. I think that supporting them and acknowledging their worth and their observation skills is the crux of making sure that our health maintenance is followed. I think I always teach when I'm talking to the class that they are our primary diagnosticians. They spend 8 to 16 hours a day with the clients, with the individuals. They know when something is not right. I might see somebody for 10 minutes or 15 minutes, and at that point in time, the dilemma might not be apparent. But I like to always give the staff credit for their observations and license to come and see anybody. Also licensed to seek treatment without speaking to a nurse. They have the skill set, they're trained in first aid and CPR, and just letting them know that their observations are critical and important and appreciated, and how important it is for us to not negate what they're saying to us. They are also, they're very critical in the transporting to appointments and making sure that the clients attend these appointments, giving any information to the healthcare providers that are needed to help with making sure that if there's a particular thing that needs to be clarified, the direct support staff, they're the boots on the ground as far as I'm concerned. Most, in my case, a lot of, we try to have the managers take the clients to the doctor's appointments, but that doesn't always work out. So we have to rely on the direct support staff. And sometimes these are people who are just fresh out of high school, fresh, maybe they're 20 years old. They're just barely getting their feet on the ground. To then understand what they need to communicate to the physicians is a little bit of a challenge at times. But I think that once we give them the credit for what they're doing, I think that they start to own some of that, and they're very committed to the individuals. So then the crux of the whole thing is passing medications correctly. And that has been an evolution since I've worked here. When I first started working here, our medication administration class was a 4-hour thing. I knew it backwards and forward. I could grade the tests from memory, and now there's a much longer process, which is probably very, very needed, because we were asking entry-level staff to do things that nurses take a year or two sometimes to learn how to do. So making sure that the staff have the proper tools to do that is really my biggest focus when I'm working with the direct support staff. It's really important for them to understand how critical passing meds correctly is. And because we have that electronic MAR, we have a scanner process. So we have a threefold opportunity to catch something if it's not correct. But it's only good if it's used. So we'll have the ability to have something scan, and a red line will come across and say, oh, you can't give that medication to that person. If you ignore it, you're still in the same, you might as well not even have it. But if you utilize it correctly, it's been very beneficial. We have found a reduction in medication errors. We've also found that staff own, I know I keep using the term own something, but when they internalize and understand their importance in the medication process, it really assists our clients in getting proper treatment, proper medication. It's really interesting, though, to see how many medications are similar across the board for our individuals, from supplements to psych meds. I found that a lot of them are similar, but I also like to make sure that the staff understand what the potential side effects are of each of those. And that's the other thing that's beneficial with our electronic MAR. You can click on a thing and it'll give you info at the drop of a hat. So, but if you don't have access to electronic MAR, the monograph system or calling your pharmacist to find out what the potential side effects are is another avenue of finding that out. I guess that's pretty much my thing. As far as medication administration goes, it's really important, I think, that the doctors communicate with the pharmacy. And I think the pharmacy has also been very helpful in acknowledging when something shouldn't have been ordered. Like, for example, if there's a cross reaction between an antibiotic and a psych med, that's where the pharmacist really comes in handy and really has averted a lot of problems for us in the last couple of years. We've only been using that system for 3 years now, but I've been through 3 different pharmacies since I've worked here. This is by far the best system that we've had right now. Are there any questions? I hate to talk at people. So.
I got a couple questions here that came through, and I want to encourage people you can raise your hand at the bottom of the thing under reactions if you want to raise your hand to ask a question, or you can just unmute and ask a question, or you can put it in the chat if you don't want to talk. The first question is, there's medication and over-the-counter medication. Do they have to be treated differently? So, you might have aspirin or things like for, a headache or whatever. How does that work?
Our clients have to have a prescription for every medication that is passed to them. Tylenol, any over the counter, you still have to have a prescription. When it comes to over the counters for as needed medications, you need to have those very clear cut parameters. And that's by 65G standards, that you need to know how many times they can have it in a day's time, when you need to call the doctor if it's not working. But they do need to be locked up and kept the same as any other medication.
Like, let's say let's say a program wasn't having the non-prescription stuff kept separate, not locked or anything. Would that be something that the agency with persons with disability or Clarent or ACA, whoever looks at you, would they make a finding if you didn't have that?
Yes, because your clients are at grave risk if things are not locked up. As a matter of fact, we have med carts in all of our home, but there are ways to lock things up without a med cart. They can be locked in the closet, but everything needs to be locked when it's not in use, when somebody is not standing at there, unless your individual has the right to keep his or her medications in their room. They still have to be in a locked situation, and their authorization for medication administration would have to designate that they're capable of passing their own meds, at which point you would not keep track of their meds. They'd be responsible themselves, but they still need to be kept safe for all who live in that environment. So if somebody lived in their apartment by themselves, I don't know, I'm not 100% sure, because we don't have any of those, but I think that they're allowed to keep their medications because nobody else should have access to them because they live by themselves. But anybody who lives in a group home setting, the medications need to be in a locked setting, whether it be under the control of the individual who has the ability to pass their own meds, or in a group lock setting. Now, even if they have the ability to pass their own meds and we don't have to keep record or do a MAR, they can keep their meds in the community lock setting. They just would have to ask you when it's time for them, and then you could pass them to them and let them take care of them. They have the option of keeping them in a group lock setting, but they do not have to. But they do have to be secured from anybody else who might live in the same setting.
And a question came in: what EMAR is being used in Arc of Alachua?
We use Care Suite.
Okay. Another question is, what you had mentioned earlier that you've reduced your your errors. What are the top errors that normally happen for providers, and what are the strategies to reduce them?
Right now, our primary med error is the client refusal, which requires us to send the documentation to the doctor and requires us to file those reports with APD as well. As far as reducing them, when a client says they're not going to take their meds, I ask that they be given 3 opportunities, not in quick succession, but 15 minutes apart. If they're still saying they're not going to take their meds, then we go ahead and send a medication error off about that. As far as the other ones that have been most prominent lately is just the fact that something goes missed. For example, somebody gets an antibiotic, so it's not on the usual rotation as far as the staff is used to giving, a 7 a.m. and a 7 p.m. Maybe they have a noontime dose. So for some reason, the staff is not in the groove for that, and then they miss those medications. So that's really the 2 top medication errors that we have.
Well, let me ask you, because if someone doesn't want to take their medication and you try 3 times, it's considered an error just because the medication. Are you somehow dinged for that? Is there?
We are not. We are
Okay.
not, because they have the right to refuse at any point in time. And that's what I try to make sure the staff understand, because they do take it personally when somebody is refusing their meds, and they do think because their name is on that medication error sheet that it goes against them, but it does not. It goes against them if they forget to give a medicine, or they give somebody the wrong medicine, obviously. But when a client refuses, we have to acknowledge that that is their right to refuse. So we do our best to not, because they're ordered for them for a reason. And we try to encourage the staff to work with the client. For example, if a client typically refuses their meds and you know that, then don't wait to the last minute to start passing the meds. Give yourself some time, or involve a staff that they might have a different relationship with, and they might just not be feeling the love with you that day, but you can maybe enlist the help of somebody else on the home to help you.
Here's a question that I've always wondered about. So this is not someone else, it's something I've thought about as an attorney. If a client doesn't want the medication, and I know a lot of our intellectual developmental disability clients may not have capacity, what do you do then? Because I guess the word I'm looking for is, if they don't assent to taking it, what do you do if it's not their decision because they don't have capacity? There's someone else making decisions for them.
Well, I can't force anybody, I can't force anything down anybody's throat. So usually what we do in that circumstance, when we have somebody who is complete, we usually try to work with the doctors to see if there is some other way that they could get what they need. Now, I have found that usually in my population here, it's not really a matter of capacity or that. It's more like they don't feel like putting cream on their feet. It's not necessarily a seizure med or a psych med. And a lot of times we found that the clients think that they're going to get the staff in trouble by refusing the medication. So sometimes it's a behavior that they exhibit because they're mad at one of the staff. But I also tell the client and the staff, that's not a reflection on the staff if you're not taking it. It's a reflection on the fact that you're not wanting to take it, and you're the only one that gets harmed by that, not the staff, unless it leads to, and usually we don't have it where it's days running or anything like that. It might be a one-off that somebody might refuse a medication.
So if one of these providers is, let's say, a group home or a smaller place, and they've heard this presentation, they go, I want to do this right. What is the first step they should do? How would you, like you mentioned that you use one pharmacy. Would that be like the first step, is you want to, or what would you do if you were just, like, let's say you're going to a group home and you want to make sure they get it right? What would be the steps they should take?
I would say organizational skills. I would say laying out what you need to make sure you have every month. So then once you know what you need to have, going through your pharmacy and making sure you've got the scripts that match up with it. And the pharmacy can help with that, because they cannot dispense without a prescription. So I think that the organizational skills we here require our managers to go through the medications 3 times a week to make sure that they have on hand what they need. Our particular pharmacy, I get what that's a good question, because now that you ask me that, right now our pharmacy delivers once a month for the standard medication. They deliver every day for other things, but the way our medications are packaged, we pass the first of the month day out of the first of the month pocket. So it is based on a calendar day thing, and that has greatly helped us reduce missed medications, medications that are routine, are given on a routine basis. And I would say that, I think the pharmacy is key in our world. I can't, your smaller organizations where you might have to get, and I have to acknowledge this, you might have to get your medications from different pharmacies because you don't have our pharmacy is a closed pharmacy. It's a non-retail pharmacy. So it just, services ALFs and bigger organizations. But that has been, for me, I think if I had a smaller group home, I think that's where I would start.
Okay. Any other questions out there?
I think the other thing too is staying on top of the training, staying on top of your staff's training from the standpoint of making sure that they are trained with that basic medication administration class, not expecting them to be ready to go the first minute they've taken that class. I think the, having the opportunity to watch meds being passed a little bit. I know that probably is a luxury for smaller homes when you need to get staff available to pass medications, but having a generalized understanding of what they're doing before they start doing it is key.
What do you do if you're handing out medication and you get to the point you basically have the wrong amount of medication for the person? So like you get to the end of it, you find you still have 4 pills. What would you do if that happened? Or what if you had 3 pills less than you're supposed to have? And I know at the front end, you're trying to make sure you get it right, but what do you do at the back end if you don't have it right?
Well, that's a dilemma. And so in our case, if I have 4 pills extra, then somebody signed that they gave it when they didn't. So that's why I also ask that not only are they popping that medication from our bubble packs, but they're putting their initial next to the date that they do it. And then we have to go back and try to figure out just where they didn't get what they were supposed to get. And that's where that organizational skill comes in, because you shouldn't get to the end and have 3 extra pills without knowledge of it prior to the end. You should be, able to see that, oh, this didn't get passed on that day, or I shouldn't have these extra, and should be able to figure it out before you get to the end. Then if you don't have enough, that's another problem. That means they also got it beforehand. Sometimes it might be, the person dropped it on the floor and you're 1 shy. Usually we just call the pharmacy and they'll send a replacement, but I do ask the staff to make sure that that's exactly what has happened, before we ask the pharmacy for a replacement.
Okay. And who monitors you? And is it the same people that monitor group homes and everyone else? Is it
APD?
Is it APD? Is it Clarence? Who's
No,
doing monitoring?
well, we have APD monthly and annually, and then Clarence, I believe, once a year, depending on our score from the year prior. But we do have Clarence too.
And when Clarence reviews, are you there going over it with them, or they just go in and do their thing and then come back?
They ask for particular records for particular individuals, but they usually are looking at staff training. I don't think Clarence necessarily, they'll go in and check and make sure our med cards are locked, but I don't know that they ask to see the medications, like the monitoring by APD on the monthly and annual basis. Sometimes they definitely look at the training documents. We've had times where they've asked for the basic medication administration certificate and all the validation certificates, making sure that they're up to date if they're passing medications. But yeah, there's a different level of frenzy when it's Clarence and when it's Clarence does our organization as a whole. So they'll give us a list of people whose files are going to evaluate. They'll look at, somebody from this group home, somebody from day program, somebody from the maybe supported living side. And then they'll ask for those records and any staff who work with them and any quarterly reports and all of that. The annual monitors, APD, and the monthly monitors, they're going into the homes and looking at the medication records, the prescriptions, making sure they match the medication itself as well as what is listed on the MAR. So it's a different level of those particular monitorings are done by the managers at the group home. That's done with that and the residential directors. Clarence is an agency-wide frenzy.
What happens if a client gets Baker-acted and they're in your program or whatever, or worse yet, if they get arrested and end up going to a county jail? What is our involvement to make sure wherever they go, because it may not be, a Baker Act facility where they might have medications, it might be a jail or somewhere else. What's our role in ensuring their medication, they stay on their medication?
I have not had I've been lucky to not have to deal with the arrest situation. I have found that the minute they're out of our care, Baker Act, we've had several in the last couple of months, they really do their own thing. Very seldom, I mean, we'll send a med list, but very seldom do they even contact our psychiatrist. They usually just stabilize and may change things and then send them home to us. And then we have to make sure that their psychiatrist wants to either adopt the new regimen or go back to what it was before. A lot of our Baker Acts are behavioral related, not necessarily psychotic breaks or things like that. So a lot of times they go for these Baker Acts and then they come back and our psychiatrist puts them right back on what they were on and they just kind of go along. As far as the, I don't know what our responsibility would be if somebody was arrested. I mean, I think we could tell them what the thing is, what medications they're on and make sure that they have access to it. But we really find that communicating with the hospitals, and I don't know about the jail system, but is very challenging. And we send a list of current medications every time somebody goes to the ER. And every time they come home, they have not updated what we sent. So it's a little bit frustrating from the standpoint. And that's where that organizational thing comes through, because within 24 hours of them being, of a client being released from a Baker Act setting or from a hospitalization, those orders need to be reconciled against the prior orders. So there's a level of responsibility there.
And so if they end up leaving your program, what do you do with the extra medication?
We, if they leave our program, depending on what the circumstances are, we either send it with them if that's appropriate, or we do a record of things and destroy them.
Danielle Haggerty has had experience. She's a provider, and she says in the comments that they've had clients arrested and they send the med list to the jail, and the jail provides meds while the client is there. So I just wanted to thank you, Danielle. We appreciate that.
Do they provide all the meds that the person is on? Because a lot of times, like
I can tell you they don't, because we know of one child, one young adult that's that there's some challenges going on now. But you gotta, when they leave and get arrested, you do want to work with the jail to make sure they know as much as you know.
Sure.
There's a unique situation I heard about from some provider out there that the agency had visited, and they were in the process of, they just given meds and they were getting ready to close it, but the doorbell rang and they got it, and they opened the door and they saw that the med was open and they got an alert.
Yeah.
So explain to me why some of these things are so critical, because I wouldn't, as a layperson that doesn't work in that situation, I would have thought, yeah, well, they went to answer the door. What do these take 5 minutes to lock everything up and stuff? So can you talk to me about how important these alerts are, and just from experience?
They're critical. And I will say that, yes, it only took you 5 minutes to answer the door, but it only takes 2 minutes for somebody to go in and take a bottle of Tums or, drink a bottle of cough syrup. And a lot of our clients are pretty savvy. They look for that opportunity. So I can't tell you how many times we say to our staff, I don't care what happens. If you have, even if you have to put everything away and start over, you close that up and you lock it before you answer the door, or answer the telephone, step into the kitchen, any of those things. And alerts are critical. They can knock your agency down quite a bit when it's something that is totally avoidable.
And what is the rule for medication again, just so everyone knows? If they want to look it up, you can Google it and find it.
65G-7.
And is there anyone else that has a question? Any other topic? Lisa, thank you very much.
Thank you.
I appreciate your commitment, your years to doing what you do. I know you made a difference, because I've talked to people that know you, and we appreciate it. So unless there's any other questions about medication management, I was gonna talk a little about, the legislative agenda, because I know there's providers on there, and I know they're interested in what's going on with advocacy. But before I do, does anyone have any more questions about medication management or any, anything they want to share about it? Okay.
Thank you. Thank you very much.
Thank you, Lisa. You did a great job.
Thank you. Bye.
Bye.